everyone. Welcome to Stories of Care. Today we have a special program for you where we're going to be talking about something that's near and dear to all of our hearts, hand hygiene. And to talk about that, we have our guest, Dr. Michelle Dahl from VCU Medical School. Welcome, Dr. Dahl. Thank you so much for joining us today.
Thank you so much for having me.
So we have so much to talk about. You have done a plethora of work in this field, from implementing a new system to doing research and trying to train people. But let's just start at the basics. Tell us a little bit about yourself and where you are right now.
So I'm a health system epidemiologist for VCU Health. So we have a couple of system hospitals in the system, and we talk about hand hygiene quite a lot across the system. I also am the director for a Virginia infection prevention training program where we provide education in a tiered system to meet the needs of multiple healthcare provider types, depending on what role they have and how long they've been practicing in the field.
Do you focus then mainly with clinicians, or do you work with everyone in the full spectrum from environmental services on up?
We really work with everyone because, as we know, medicine is a team sport. Nobody is doing this alone. And so there's a lot of different types of providers that touch the patient and the patient environment. And so we work in a very multidisciplinary way.
And what got you even interested in infection prevention to begin with?
So I am infectious disease trained. So I did my training in infectious disease, expecting at that time to start with clinical infectious disease. And I still love the clinical care aspect, but I really liked thinking about the science behind our healthcare associated infections and what are the risk factors for those and what can we do better. And I think there's just so much that we still work to do in this area. So a lot of times these days, we kind of know what those risk factors are. We know the things that we need to do to prevent these infections, but making that common practice and implementing this consistently is really a struggle with all of the other competing priorities in healthcare.
Mm-hmm. And I have to say, I relate so much to entering ID with the thought process of being mainly clinical, but that's what I love about ID. I feel like there's so many ID doctors doing the most random types of jobs you never thought you would have a pathway to. So it's a really cool field, but I'm a little biased. So tell me a little bit about how you started up. You started up a new program with infection prevention and control. And it's a different method. It started even before the pandemic. So I kind of want to understand what made you say, hey, what we're doing is not working. We need to come up with a new thing to do.
So I'm sure we'll get into this in detail later, but of course, working on hand hygiene requires a multifaceted approach. And so a big part of that is education. The problem with education is you have to do it again, and then again, and then again. And the minute you stop doing the education, you see the practice lapse. And so hand hygiene is always a focus. I think this is true for every healthcare system. We had a previous vice president of quality and safety who felt really strongly that we were not going to move the mark on hand hygiene any further unless we did something vastly different. And at the same time, there was a lot of these new automated monitoring technologies coming on the market and some data around what that looks like. So we had implemented.
What were you doing? What were you doing at that time that made, what was the norm for you?
The norm, I mean, our program involved monitoring hand hygiene. So we did that with trained observers that would go out on the units essentially as secret shoppers. A lot of places do this, and they monitor hand hygiene behaviors. We report that back, and we make that data very visible. So we show it to our leaders. We feed that back to each individual unit. And then we talk about, when the hand hygiene starts to fall, we sometimes will visit those departments and discuss that the hand hygiene has fallen and needs to improve. So it's a combination of a lot of data fed back, a lot of data collection, and then a lot of education that goes along with that. They're systemic. Yeah.
Oh, go ahead. I was just going to say, so where did you find that you were stagnating with that?
We were stagnating right around the 80% mark. This is close to goal. Our goal and this is important. So we monitored room entry and exit hand hygiene, which is not all of the episodes of hand hygiene that we should be doing, but is the key parts of hand hygiene that's feasible to monitor for those observers. And so a lot of systems will monitor room entry and exit as kind of a bare minimum. And that's where we were hitting that 80%. We really were hoping to see it go higher. And the hand hygiene technology, the automated system, was an effort to really get a better sense of the practice, because the other the other limitation to the observers is that it's very labor intensive, and yet they can only monitor a very small amount of the hand hygiene that's actually occurring. So they'll spend a day on a unit monitoring the hand hygiene, and they'll only capture a handful of providers in their practice over time. Whereas when you have some of these automated systems, then it captures all the hand hygiene, right? Anybody who's wearing the badge for the system, it captures their hand hygiene. So you get nights, you get weekends, you get data that you wouldn't have had before.
So with you discussed that one of the flaws was it really only looks at entry and exit of the rooms. What are some other critical points that often get overlooked when it comes to hand hygiene?
Right. We say hand hygiene is the simplest, most effective way to prevent infections, right? But it's a little bit duplicitous because, yes, it's simple in theory to do that one episode, but the expectation really is that we are constantly doing hand hygiene as healthcare providers, and that is the hard part. There are estimates that some providers in the course of their work will have up to 50 opportunities for hand hygiene within 1 hour. So if you think of how much time that would take you to do hand hygiene 50 times, that's a good chunk of your hour. So at some point, there's been a suspicion that is there some point that's not attainable to have that 100% adherence depending on the acuity of care. There are studies that have been done that show that somewhere around an excess of 30 opportunities per hour is where we really start to slip. And this is data that comes out of the a previous like multi-center study involving a lot of ICUs. So looking at the hand hygiene practices there, the adherence really starts to fall when you have that many opportunities, that high acuity of care. Meanwhile, we're monitoring just the room entry and exit in general, because that is what somebody unobtrusively, respectful of patient's privacy is able to do in the hallway, right? Meanwhile, within the room, there's all these opportunities that we are supposed to be doing hand hygiene. Really, anytime you're going from a dirtier to a cleaner part of the patient or the environment, anytime you're going from the environment back to the patient. And because we're usually monitoring by observers that room entry and exit, a lot of providers at this point are under the impression that's the only time that it's required, when really we're missing a lot of in-room opportunities that are under-recognized, I think, based on how we monitor.
No, you're right. I have to admit, especially because, as we know, when it comes to accrediting bodies of hospitals like JCO, they often also do this observation method. So it's always drilled into us: entry, exit, entry, exit.
These automated systems are also a heavy lift. Any system who's installed one of these knows that there's a lot of like ongoing maintenance to make sure that all of the system parts are working. You have to continually validate it so that people trust in the data. And we still, every time somebody doesn't like the data, of course, we spend a lot of time defending the data and explaining that we have tested it. It works reasonably well, nothing being perfect, right? So I think there's pluses and minuses to both methods. And I'm certainly not saying that if you really cared about hand hygiene, you'd have one of these systems. That's not true at all. There's a lot of ways to work on hand hygiene, and that's just one tool that you might consider.
So tell me about this automated system. Where is this? Is this a new system? When did it come up? How did it come up?
So we had started this installation 2 or 3 years before the COVID-19 pandemic. And because it was a massive undertaking, this is on our main medical center. And we individually badged pretty much anyone who on the inpatient side would have reason to come in and out of a patient room. So if you interacted with the patient room or that environment of the patient room, then you were badged for this system. And then every time that you approached a bed, the patient zone was defined by an area under the patient bed. It would look for you to have done hand hygiene. So we did this because it was such a massive implementation. We did it in a stepwise fashion. We did some units first and then brought people on board after over approximately 2 years.
Exactly how does this work? Is this kind of like a little camera? Describe the system to me. I'm very curious.
Sure. So it's a tiny badge that you clip essentially to the bottom of your ID tag, and then you wear that when you're out on the units doing your clinical care. And there is a sensor in all of the hand hygiene alcohol rub dispensers, as well as all of the soap dispensers, that looks and individually identifies you in the system as you're doing hand hygiene. So if I come up, it'll see Michelle Dahl is here and she is doing her hand hygiene. I've gotten enough of the product out, and then it will look for me to have done that at some station before I approach a bed. and then again after I leave that bed. And there's a certain, and some of these settings are customizable. There is a certain amount of time that you are allowed, considered to be clean after you've done that hand hygiene, or a certain amount of time that you have to get, say, to a sink on the other side of the unit if it was a C. difficile room or something like this. So, and all of that is, you can kind of tweak if you have different provider workflows that need some adjustment.
Did you find though that that this automated system was showing that your hand hygiene was better than you thought from just observers, worse than you thought, about the same?
So interestingly, it correlates really well with the observation data. And we see that when we break it down by provider type, we see that when we break it down by unit. They tell similar stories, which is also really reassuring to be able to tell our providers the data is saying the same thing, regardless of how we are collecting it. One of the biggest differences, though, is just the vast amount of data that the system collects versus what our observers can. It just pulls an enormous amount of observations over the course of the month, whereas the observations are kind of like a drop in the bucket. But we have still continued to do both because we think it's important, again, to show that correlation and the matching, and also to have eyes on the actual practice. So I would say the data is valuable. One of the most important ways we've used that data is when the data is not, when we see that there are opportunities for improved hand hygiene. Sometimes in the exploration, we realize practices that are going on that were not even on our radar. And an example of this would be, one of our ICUs, this was pre-COVID, we're not happy with their numbers, and they said, this is not capturing us well, especially in our contact isolation. It is unable to capture us when we're in that environment. And what we realized was happening is that these providers would do, there is data to say that when you are taking care of a patient who is on contact isolation, you bundle your care so you don't have to keep going back in and putting on the gown and then taking off the gown and a new gown. So you try to bundle up all your activities. So we saw that our providers would gather all their items, put on the PPE, they do their hand hygiene going into the room, and then they'd provide excess of 20 plus minutes of care to that patient, doing everything under the sun, and never do another episode of hand hygiene during that whole time. And then they would do hand hygiene again on exit. And so there were a ton of these missed opportunities within the room. And so it wasn't that the system wasn't working, it was kind of exposing these other opportunities that I think nobody even recognized were there and being missed.
And so when you implemented this automated system, the new data that you generated, even though it coincided really with your observations, what did it enable you to do as far as enhancing the other parts of the hand hygiene protocols, the education, the trying to bring in more of these conversations? How did that change that behavior?
This allowed us to kind of drill down in more detail on whose hand hygiene we're talking about when we're feeding back data. So for example, with our observation data, the best we can get is drilling down by role. So I can say I can lump all the physicians together. We know this person was a physician, but we don't know what department, division. The same thing for the units. We would say this person the hand hygiene was happening on this unit, but we can't say who on that unit it was. So when we're discussing hand hygiene by observation data, some of the common things we hear is, well, from nursing, for example, our nurses are doing the hand hygiene. These people who aren't doing hand hygiene on the unit are not ours. They're not mine. They're the consulting physician. They're EVS. They're whoever else is not my people. And then the same thing for the physician side. Like, our department does great. It's all these other providers who aren't doing. So this really puts transparency there, right? It is individually identifiable, and so I can look and say, pull out just infectious disease and see, this is how infectious disease is performing, and then compare against other divisions.
So with the automated system and the increased accountability and transparency, are we able to gauge now which groups, which professions, which people in the hospital are actually doing hand hygiene the best?
So we didn't necessarily need the technology to tell us this. There's really good data that's consistent over years and years that are some of our best performers of hand hygiene in the healthcare setting are our nurses. And then physicians do not as well compared to other provider types. And that's consistent. On the flip side of that is that if there is a role that we really need good hand hygiene, the level of care and the things that they're doing at the bedside. If you are a nurse, there is a lot of contaminating activities going on. There are a lot of critical moments of hand hygiene that group is responsible for. And so if there is a group that really needs to do really good hand hygiene, it is bedside nursing and those roles that assist in bedside nursing. So the nursing assistants or care partners who are active on those units. I'm not trying to excuse physicians. We need to do better. Our patients expect us to do better. There is also very good data to say that whatever the attending physician or the physician leader on the team does, everyone else who is following them, down to the residents or trainees and students, they will all follow suit. And so it's really destructive if we're not modeling good hand hygiene as physician leaders for everyone else in the environment.
When we work with nurses, and you're talking about that they have to do it at so many different critical points, and that you had mentioned earlier when they get up really over 30 in an hour, it starts to become almost overburdened. How do we overcome that, especially when we're putting so much on nurses? We're talking about nurses being overburdened just with their everyday jobs as it is, because we're constantly giving them more patients and more responsibilities and higher needs with each of the patients that they carry. How can we fit in, hey, you also need to continue to do more as far as hand hygiene, even though you're already doing it 30 or more times an hour?
So it's a good question, and I don't think there's an easy solution. So just because the care is high acuity and it becomes difficult to hit those targets doesn't mean that it's okay not to hit them, right? So you still need to make every effort. I think at a higher level, at the system level, I do think that the workload increasingly needs to be considered. So all of the documentation that goes into the EMR, how can that be made easier so that so much time isn't sucked up putting things into the EMR? Where are the things that there's not a critical task for a nurse level to do, for example, in the ICU, that would allow them more time to spend at the bedside, and make sure that they have the attention to detail to those infection prevention priorities that are the one, like practically speaking, they are the things that we start to cut corners as healthcare providers when we have to make those hard choices. And so I think it's important to consider workload in the background of all this. But I think as the individual provider, I'm still going to need to do everything I can, even in the context of whatever is going on in the workload, to squeeze the hand hygiene in.
How do you help the larger offenders to improve their practices?
So in the short term, all it really takes often is a meeting where you review the data, you remind why this is important, and remind it's more than just room entry and exit. And we've seen that really work with, at least in the short term, the rates improve. I will say, in full transparency, this is an ongoing issue, and we are at my facilities dealing with this right now. We have, since COVID-19, we have a lot of new team members in the environment. There is a steep learning curve for a lot of things, and hand hygiene, unfortunately, is not always the priority. And so this is an ongoing battle for us. We are not happy with where we sit at present, so I can't say that we are doing everything right, but certainly it's something that we continue to battle. And it is one of those things that when you stop talking about it, when your leaders stop showing that it's prioritized as important, the practice will fall without those constant reminders.
No, and that makes sense. With COVID, as you said, it deprioritized this aspect as our talking point. So I imagine that we definitely saw impacts there in the longitudinal aspect of it. But in the immediate, right during the start of COVID, right immediately after kind of we were seeing the uptick in cases, did you notice any trends in hand hygiene? Did it improve or decrease, or did it still essentially just stay the same, even though you were not talking about it as much?
So there was a couple studies published from during that time that right when this pandemic was starting up, hand hygiene improved, and we saw that as well.
How long did that take before you started to see the hand hygiene numbers start to slip during that period?
That's a good question. I couldn't pinpoint for you an exact time period, but somewhere late 2020 into 2021, we saw that kind of regress back to baseline, I would say.
Mm-hmm. And so then it was at baseline for a while. At what point did it start to dip even below baseline?
I'd say since that time, been a continuous downtrend, at least at our facilities. I could not speak for others. I have not seen as much data published since COVID-19 on overall trends, but at least in our facility, it continued a slow creep down across most of our units.
Okay. And what are some of the tactics that you're using now to try to address that dip?
More visibility of the data. So during this time period, the infection prevention department that runs the hand hygiene program, we're also pulled in a lot of different directions. And so some of the reports had not been sent out as routinely. The maintenance for that hand hygiene automated system had not been kept up. And so that data was not as useful. So if we don't think the data is right, we're not going to send it out. So we had to first address the system that needed its maintenance, that needed its upgrade, and do all of that. And then when we have the reports that we have confidence in, make sure they're circulating more widely. So some of that is also the priorities of our group were stretched thin during this time.
And for people who aren't in as robust a system as yours with so many infection preventionists, what are some resources that they can use for maybe even the community hospital or local hospitals to be able to understand the importance of hand hygiene and then help educate their peers?
That's a good question. And there are some great resources out there. So the WHO, I'll start there, has developed an evidence-based multimodal hand hygiene program, and it's focused on 5 different areas, core areas, but basically hinges on making sure that the environment is set up to promote hand hygiene. So are the dispensers full? Are they in locations that are easy to access, and all of those things at the system level? And then there's a lot on education, getting the data, feeding back the data, and having this ongoing discussion about hand hygiene. It doesn't have to be high tech. It doesn't have to be super fancy, I would say, but it does require that ongoing interface with team members about the importance. And that's really something that any facility can do to some extent. There is evidence that each piece of this is valuable. So even putting reminders in the environment has benefit. There's some fun things that facilities have done and can do to try to make this less painful, more fun. And some of those things I've done is there is a fluorescing powder that infection preventionists will often use to teach good quality hand hygiene. So you coat yourself with the powder and you do your hand hygiene, and then you get out the black light and see how well you did. Is there stuff still stuck between your fingers on your ring or wherever? So there's fun training that you can do to, again, just bring attention to hand hygiene and remind us of how important it is.
And then another big piece of the puzzle here, we keep on talking about it from, the JCO perspective, the hospital administration perspective, the oversight perspective. But what about patients? Do they notice hand hygiene? Is it something that we have data saying it's not really a big deal, or this is something that's really a huge deal to them?
Yes, thank you for bringing that up. There's been a lot of work also in the medical literature looking at the patient perspective on this. Even anecdotally, if you talk to the members of the general public, they really struggle to understand why we as healthcare providers can't wash our hands. They see the statistics and they just, they don't quite understand, I think, the amount of times, the amount of opportunities there are, et cetera. That being said, there's some of us in the environment who have really poor hand hygiene practice. Their patients really want their providers to have clean hands when we touch them, obviously, but most patients are not going to ask you to do hand hygiene, and they have some good reason to be shy. So when patients have been interviewed about this, they have concerns that if I ask a provider to wash their hands, it will negatively affect the relationship between me and my provider, or it will affect the quality of the care I'm going to get because now this provider won't like me. So there's a lot of patients that are very kind of afraid to have that discussion. And there's some reason for that. In general, I think that this conversation can go well, but certainly in my role, I have it escalated to me when a patient has tried to have that conversation and it has not gone well. So if the provider sometimes can become very defensive and and say, how dare you kind of question my practice? Of course, I'm doing everything right. If the patient has been assertive enough to start the conversation, you can see how that can quickly escalate to something that's very uncomfortable for everybody involved. So I think if you have the patients who are savvy enough to ask, maybe they've had heavy exposure to healthcare and decide it's going to be worth the trouble. I just really need to know the correct response. And I've been asked this, of course, is to just say, oh yes, I will go. I want you to be comfortable with me coming into my exam. Let me do my hand hygiene where you can see me. And the implication is like, of course, I've done it when I'm coming into the room, but I don't need to kind of drill that in. I'm going to do it for you now so that we're all on the same page, right? Keeping in mind too that a lot of the more vulnerable patients are probably also the ones who, yes, want you to still do hand hygiene, but aren't going to be maybe empowered to ask. And so especially, I think for those patients also, I always try to make sure that they can see me as I'm coming in the room, that I'm washing my hands. And if I'm doing things within the room, I throw in some hand hygiene just so that they know that it's important to me that I'm doing good hand hygiene practice. Patients are looking at this.
If you had to leave everybody who's listening or watching this with just one message, what would you want to tell them today? What do you want them to take out of our conversation the most?
That hand hygiene, even today, in 2024, still saves lives. It cuts down those routes of transmission. And likely all of us, myself included, could do a little bit better in our own personal hand hygiene. So just be open to considering where the opportunities are that you might be missing. And also the other thing, sorry, you asked for one, but here's the second one. If a patient asks you to do hand hygiene, you smile and do it so they can see you do it, and make sure they're comfortable with you coming in to do an exam. Yes.
I love it. I love it. One that's clinician focused and one that's really patient focused. That's great. Well, I couldn't leave it on a better note. Thank you so much, Dr. Dahl, for being here with us today. This has been a great conversation and very valuable on how we can try to address infections before even needing ceftaroline by just doing good hand hygiene.
Well, thank you so much. It was my pleasure.
Stories of Care is a publication of the AMA and CDC's Project First Line. Project First Line is a national infection control training collaborative working to provide all healthcare professionals with the foundational infection control knowledge they need and deserve to protect themselves, their patients, their coworkers, and their communities. For more information, trainings, and other infection control resources, visit cdc.gov/projectfirstline and amafirstline.org.